speaker. And the next speaker is Dr. Toshinori Murata. He's a professor at Shinshu University. He has graduated from Kyushu University School of Medicine, Japan in 86. 96, he was a research associate at Doheny Eye Institute. Then 1998, he was a research fellow at Harvard Medical School, Boston, Massachusetts. 2004, he became an assistant professor at Department of Ophthalmology, Kyushu University. And currently, he is professor and chairman of Department of Ophthalmology, Shinshu University of Medicine, Japan. And also, he was a president of Japanese Ophthalmic Society from year 1919 to 2022. So it's our privilege to have you, sir. Welcome. Welcome to our country.
Okay, thank you for kind introduction, and it's my honor to be here to give this presentation. I'm going to talk about diabetic macular edema with treatment with Bralucizumab. I think we have almost 3-year experience, and this is my COI. So for second generation new anti-VEGF agents should have strong efficacy, achieving early vision recovery after 1 or 2 injections. That's ideal. A longer interval durability, making eventual discontinuation of anti-VEGF injections. Otherwise, it's very expensive treatment, so patients cannot afford. So, yeah. Preserved ellipsoid zone indicates intact photoreceptors, and if we start Bralucizumab injections at this time point, it almost always results in very good vision. It should be 6/6, I think. And on the other hand, if in the chronic macular edema, ellipsoid zone photoreceptors are already lost. So even if the Bralucizumab make macular edema resolution, it does not result in vision improvement. So the effect of early treatment has proven by Protocol V. They treated within 4 months after the vision deterioration due to diabetic macular edema. An average visual acuity of 20/20 was achieved in their study. So next step is macular edema resolution and vision recovery after 1 or 2 injections. So we wonder why. Why are 3 to 5 monthly injections, meaning induction phase, are always included at the beginning of protocols of phase 3 clinical trial in diabetic macular edema? It was with first generation anti-VEGF, and until it falls below the cutoff value threshold, a reduction of central macular thickness does not lead to vision improvement. But once it goes below the threshold, dry macula is achieved and vision got improved suddenly. And with Bralucizumab, we don't need 3 to 5 injections. So let me show you a patient. Vision got improved after single injection. In this patient, a Bralucizumab was injected, and 6 weeks later, the vision is already 20/20, and there is dry macula. And I think you talked about pan-retinal photocoagulation. I think it helps. I will explain it later. And you may think this is very, very exceptional case, but we experience many cases like this. And it has been proven in phase 3 study, KITE study, aflibercept was used as control drug, and 4 weeks it reduced maybe this number. And Bralucizumab, it has longer duration of interval, and 6 weeks later, CMT gets much thinner. So this is from Kestrel's study we belonged. We belonged to Kestrel, another phase 3 study, and among Japanese population, the baseline was 437 micrometer, and just single injection of Bralucizumab reduced its 125 in average. So simple calculation, based on simple calculation, a single Bralucizumab injection may reduce central macular thickness to below 320 on average, which is the threshold for macular edema that may result in vision improvement. I know this is too simple calculation, but there is possibility. In Japan also, because of the concern for IOI, the market share of Bralucizumab almost reached zero as Western countries, but it came back now. It's 20%, and for PCV, it's almost 30%. And this explains why. Among Japanese population, Bralucizumab-treated eyes shows the early edema reduction effect, which was pronounced in Japanese population, while it was not prominent in overall population. That means Western countries, I think. And we are allowed, there are so many regulations and restrictions, so we are not allowed to see or touch the data from other Asian countries, but I believe it happens among Asian countries. And this is a case from phase 3 study. In this case, a single injection resulted in 20/20 vision, and fluorescein angiography shows marked reduction of leakage. An average injection of Kestrel study was 11, so he underwent 11 injections, and vision was 20/20. And there have been no recurrence of diabetic macular edema for 3 years and 7 months. So it appears 7 Bralucizumab injection led to complete cure, no further injections. We are not the only ones who thought that Bralucizumab can make discontinuation of injections possible. Surprisingly, from Western group, they reported 3 out of 4 patients did not show recurrence of diabetic macular edema after phase 3 study. And they also suggested a dry macula obtained by Bralucizumab. Its drying effect was correlated with subsequent discontinuation of anti-VEGF injections. And we conducted a doctor-initiated study to investigate this hypothesis among Japanese patients. And this is the most important slide. This shows many regulations prevented us to touch or see the data from all patients. We could see the only 19 cases we ourselves treated, and 15 out of 19 cases were followed up more than 3 years or longer after the conclusion of Kestrel study. So among those 15 patients, 8 successfully discontinued injection. And when we focus on Bralucizumab, 9 out of 10, so it's about 70%. And the report from Europe was 3 out of 4, so it's 75. Both studies have a limited number of patients, but I want to say it's highly likely 70% of patients can discontinue. So we wanted to find out what factors made the discontinuation possible. Then we investigated the correlation between the duration of dry macula and subsequent discontinuation of anti-VEGF injections. There are 2 types of dry macular duration. One is continuous. So the longest continuous dry macula was 3 months for this setting or for this patient. But the total duration of individual dry periods is 11 months, and we hoped 11 months works. But unfortunately, duration of only continuously dry macula was correlated with subsequent discontinuation of anti-VEGF injections. Total duration did not have effect. So the next question, the dry macular period needs to be continuous. So the next question is, how long do we have to maintain dry macula continuously? So we used first logistic regression, and the number is small, so we cannot say definite things. But when we set central macular thickness, 270, it's 5.77 months. So it's about 6 months. So if we divide 24 weeks, so it divide by 6, it's 4. So 5 injections may lead to discontinuation in 50% of cases. And the central macular thickness is thicker, it's easier. So until 290, we had found correlation between continuously dry macula and discontinuation. So let me show you a real-world case. This case motivated us to perform that kind of study. In this eye, we injected aflibercept. In Japan, I have to say aflibercept used to be or still is the first choice. And after 1 month, we did not see much difference, thickness, vision, and the area. So we switched to faricimab. It was available in those days already, and it showed a little improvement, white area over 500 diminished in size. So we injected one more time, but we didn't see much difference. And at that time, Bralucizumab became available, so we injected, and in one injection, vision got improved, and after 2 injections, almost resolution of diabetic macular edema was achieved. What do I do? I was told 15 minutes talk, so I prepared. Can I go on? Okay, so allow me to go on. So it's 2020. So just 2 Bralucizumab injections resulted in vision recovery to 2020 after switching from aflibercept and faricimab. So we kept injections, and the interval got 3 months, then it's 6 months. So we didn't put cap of 4 months. We extended as much as it's possible. And 6 months after, it's still 2020, and there is tiny cystoid macular edema. We suggested injections, and patients agreed. She was happy with this vision. And the other eye, the vision was very, very poor. So we injected 6 times, and now it's 7 months. And this is my personal impression, but if we could repeat 6 months interval 2 or 3 times, it reaches total discontinuation. So far, as of today, 20 months, no injections. So we believe 7 Bralucizumab injections have made to discontinuation of anti-VEGF injections possible. And in this case, again, this patient has widespread non-perfusion areas. So to prevent proliferative stage to progressing to proliferative stage, we needed pan-retinal photocoagulation, and for macular edema, we injected Bralucizumab. And 5 injections in total maintained dry macula for 21 months. And now no additional injection for more than 2 years after this. I used to be a basic researcher, as the doctor said. I went to Harvard and Los Angeles. An injection of VEGF itself, bad guy, into the vitreous of normal monkey eye, it induced microaneurysm formation and macular edema in the macula, microaneurysms and leakage in late phase. So VEGF from the peripheral retina also causes diabetic macular edema. So in this eye, VEGF from local macular ischemic cells exist, and it causes diabetic macular edema. But there are many more ischemic cells in the periphery, and VEGF can be secreted from the cells, and it is water soluble, so it can go anywhere. When it goes to trabecular meshwork, it causes neovascular glaucoma. So all VEGF can come to macula. And if we were treated with injection only, macula is only 2% of the entire retina. So anti-VEGF injected will be wasted 98% for suppressing VEGF from the peripheral cells. So maybe only 1 suppress VEGF from the macula. But if we perform pan-retinal photocoagulation to prevent progression to proliferative stage, ischemic cells in the peripheral retina are eliminated. So all injected anti-VEGF can be used to suppress VEGF produced in the macula. So we can enjoy longer duration, longer injection interval, and more higher possibility of discontinuation of the treatment. This is my personal opinion. So an injection regimen should be designed to keep the macula continuously dry to facilitate the subsequent discontinuation of anti-VEGF injection. Thank you for your attention.
Thank you, Professor, for wonderfully eliciting the importance of this particular